day number 1 in the 3 days PhD defense, and the first candidate will be Zsolt Huszár. After that will be followed in Katalin Lugos in neuroscience and psychiatry, where they will be here, and I am more than happy to welcome for the first 2 defense Martin Kolzenberg, who's member of Academia of Europea, a very key figure at the basic and clinical translational medicine section. Thank you very much for taking your very valuable time to come over for this defense. And he has really a significant involvement in research into pain mechanism and all these kind of field in peripheral neuropathy as well. But of course, the team is really a well-established Hungarian physicians and scientists. I'm also very pleased to introduce Professor László Szapáry from the University of Pécs, who is here today and acting as a member of the team. Also Zsolt Huszár from the University of Szeged. He is also involved highly in basic and clinical sciences. I am also very happy to introduce Bence Lázár from the University of Szeged, leading the Department of Psychiatry. I'm also very happy to introduce Tamás Kiss from Semmelweis University, who is here and taking part of the program. Gábor Varga, who is also part of the Semmelweis faculty and acting also vice director of the Center for Translational Medicine. We always have a statistician in the team, Réka Tóth, very welcome. And if there are any questions also and discussion, she can be involved. And we have also a methodology expert, Nazanin Götz, who is also joining to the faculty of the PhD defense. Now I think at that moment, I think I'm stopping. Welcome everybody and enjoy the 8th progress report of the students.
Hi everyone, I'm Gábor Csukli. Dear committee and audience, let me introduce my PhD student, Zsolt Huszár, who was born and raised in Budapest, Hungary. He attended Móricz Zsigmond High School and later studied medicine at the University of Szeged, where he graduated in 2017. During his university years, he joined the Department of Psychiatry in Szeged, where he worked under the supervision of Magdolna Pákáski on the topic, the role of stress and hyperlipidemia in the pathogenesis of Alzheimer's disease. After graduation, he joined the Department of Psychiatry and Psychotherapy of Semmelweis University as a physician, as a resident physician. Between 2019 and 2021, he served as a board member and later president of the Hungarian Association of Psychiatric Trainees, where he worked to improve the psychiatric training system and organize national conferences. He completed his specialist training and became a psychiatrist in 2023. Alongside his clinical work as a psychiatrist, he has also participated in the outpatient service for dementia prevention and cognitive assessment at the departments of memory clinic led by Zoltán Hidasi. He holds a GCP qualification and participated as a sub-investigator in multiple phase 3 clinical trials. During his residency, Zsolt participated in other research projects, including studies on stigma associated with mental disorders and affective disorders. In 2021, he began his PhD at the Center for Translational Medicine under my supervision, focusing on risk factors of cognitive decline in elderly population. As a result of our work, 2 D1 level publications have been published, a meta-analysis and an analysis on the EDNIB database, which is a public database of Alzheimer patients. He presented his results at national and international conferences, including the ADPD, the Alzheimer's and Parkinson's Disease Conference, where he presented his work in poster form. During his PhD studies, he also participated in the work of our research group, named the Clinical Neuroscience and Neuroimaging Group, helping us to collect data and build a longitudinal neuroimaging database of Hungarian patients. Furthermore, he helped the TDK students get involved in scientific research. In his free time, Zsolt enjoys reading, hiking and playing beach volleyball. During his PhD studies, he has developed outstanding skills in critical thinking, filtering vital information from previous studies, and formalizing new research objectives and hypotheses. I believe that he's ready to mentor his own PhD students in the future. Thank you very much for your. Thank you.
The committee, their audience, how could we avoid dementia? How can we recognize its risk? And what can we do for our patients? This will be the subject of my lecture. Let me share our vision that in the future, cognitive decline will be avoidable by the widely used prevention tools. And to achieve one day this bright future, we assist developing prevention strategies. We have set two specific goals. First, to examine how Alzheimer-related protein changes accelerate the cognitive decline. It was our first paper. Second, to assess the role of known modifiable risk factors of dementia according to beta-amyloid and phosphorylated tau status. And I will present now our first paper. Title is Risk of Conversion to Mild Cognitive Impairment or Dementia among subjects with amyloid and tau pathology. There are typical pathological protein changes for Alzheimer's disease, and these changes could start decades before cognitive symptoms appear. These are the senile plaques built by beta-amyloid in the intercellular space, interrupting the signaling function of neurons. And within the neurons, the neurofibril tangles develop from phosphorylated tau proteins. These disrupt the axonal transport function of the neuron. And today, in vivo tests are available to detect these proteins, for example, by PET imaging or cerebrospinal fluid examinations. And considering these new in vivo techniques, the US NIA Alzheimer Association proposed to define Alzheimer by purely biological, a purely biological definition, centered on the beta-amyloid and p-tau, so regardless of the cognitive status. But in contrast, the International Working Group still emphasize that the diagnosis should remain linked to the clinical symptoms. Among many other arguments, they point out that some of the patients, some of the individuals with pathological protein changes do not convert to dementia even after 10 years of follow-up. And to further emphasize the relevance of this question, I underscore how prevalent is the pathological beta-amyloid in the non-demented population. There you can see that in the cognitively healthy, or we will call now cognitively unimpaired population, the prevalence of pathological beta-amyloid range from 10 to 44%. In the mild cognitive impairment group, it ranged from 27 to 71%. So we know a lot about these proteins, but there is something that we still don't know. Still unclear to what extent amyloid beta or p-tau accelerate the cognitive decline. So we aimed to investigate the association of amyloid beta alone and in combination with p-tau and a progression to MCI and dementia. We investigated separately the cognitively unimpaired group and the MCI group. The exposures, of course, were these two protein changes, comparing with those who lacking these protein changes. The outcome is the progression to MCI or dementia. So we hypothesized that biomarker-positive patients have a higher progression rate. Here you can see the flowchart of our systematic search. We screened more than 18,000 articles, and in the end included to our analysis 40 studies. And now I will present our results on the cognitively unimpaired group. Here you can see our first forest plot regarding the amyloid positivity compared with amyloid negativity. We used as our main statistics the odds ratio with confidence intervals, which means the confidence intervals you can see those horizontal bars, which means where now with 95% probability the true effect lies. So if this line cross 1, the result is not significant. If does not, the result is significant. So in the case of amyloid positivity, the odds for progression to MCI dementia 5.8-fold higher comparing with those with amyloid negativity. And in this slide, you can see when we had also data on the p-tau. In the case when both proteins are pathological, more than 13-fold higher the odds for progression. But when only the amyloid is pathological, the p-tau is not, we find no significant association with progression. You can see the confidence interval starts at 0.7. Let's see the results on the MCI group. Here, the same analysis regarding amyloid positivity comparing with amyloid negative groups. We found that the odds for progression 5-fold higher for progression to dementia. And you can see this was luckily a large pool. And since the mean age differed across studies, by the help of a meta-regression analysis, we tested whether age affects the odds ratio or not. And we found that the difference between the odds in the amyloid positive and amyloid negative groups gets smaller with age. Going further, let's see in the MCI group where we had data also on the p-tau next to amyloid. We found that on the case where both are pathological, the odds for progression 11-fold higher than only amyloid pathological, but the p-tau not. Also, there is a significant association. The odds for further progression is 2.7-fold higher. However, when only the p-tau pathological in this group, the amyloid not, we found no significant association with progression to dementia. I mentioned some of the main limitations. One is the studies were pulled together with different follow-up period. To evaluate this effect, we made two other meta-regression analyses, and we found that between odds ratios and follow-up, there are no significant associations, luckily. And also the measurement technique, the used measurement techniques differ across studies. In the p-tau, it wasn't that relevant. Almost all of the studies use the same method to measure p-tau. But for the amyloid measurement, the PET scan and different cerebrospinal fluid examination were used. And we made a subgroup analysis to detect this effect. But we found no significant difference between the groups. So this means that across all measurement techniques, the risk by amyloid pathology is constant. So let's see our conclusion. It's pathological amyloid alone predicts high risk of dementia progression, and adding p-tau status further refines risk stratification. This is this imaging example how amyloid pattern, p-tau tau PET looks like. Yes, and in terms of clinical practice, we know that, by this knowledge, we know that the most at-risk population can be identified before cognitive symptoms emerge. That's why we believe that pathological protein status should play a central role in therapeutic strategies. And our implication for further research that future studies of dementia prevention should stratify or adjust according to patients' biomarker status. Also, future dementia risk assessment tools should incorporate this information on amyloid and p-tau. Thank you very much. If you follow me, now I will present our second paper. The title is Association of Modifiable Risk Factors with Progression to Dementia in Relation to Amyloid and Tau Pathology. And here I have some good news. potentially modifiable risk factors are responsible for 45% of dementia cases. There you can see, it's frozen now. Okay, there you can see these risk factors, many of these related to cardiovascular risk or lifestyle, or with lifestyle. And so we actually are all aware about how important these factors are. Yeah, there is still something what we don't know. Our question was, we point out the unclear role of modifiable risk factors across distinct biomarker profiles. So with other words, we don't know the role of these modifiable risk factors changed or not, depending on the presence of amyloid or p-tau pathology. We aimed to explore how modifiable risk factors are associated with dementia progression in distinct Alzheimer biomarker subgroups. And to answer this question, we used the open access US-based multicenter ADNI cohort, which provides very well-characterized data. We were able to examine the following risk factors. It was depression, smoking, hypertension, obesity, hypercholesterolemia. And to examine these last three risk factors, we used the so-called CAIDE dementia risk estimation tool, because by CAIDE we were able to convert to a single measure value the complex information of the overall cardiovascular health or risk. There you can see our study design. We investigated separately in the cognitively unimpaired and the mild cognitive impairment groups the amyloid positive patients, the amyloid negative patients, and so on with other pathologies. The exposures were the modifiable risk factors like high CARDA score, smoking, and depression, comparing those lacking these risk factors. The outcome you cannot see, but I tell you that it was the progression to MCI or dementia. So we hypothesized that modifiable risk factors increase the risk of progression in every amyloid or p-tau status. This is the baseline information. I underscore that no baseline association were found between biomarker status and high CARDA score, smoking, and depression. And we use as statistics the Cox regression adjusted hazard ratio, which means we corrugated with the information on age, sex, education level, baseline mini-mental score, hippocampal volume, and upweight for carrier status. So let's see our results. I will only present the MCI group. What can we see here? This is a survival analysis. So the dementia-free survival by the follow-up period on the horizontal axis. The red lines are the modifiable risk factor positive subgroups. The gray ones, the modifiable risk factor negative subgroups. And remember, our goal was to compare these modifiable risk factors separately in every biomarker subgroup. So, for example, in the first figure, the more pale lines are the amyloid negative subgroups, the more solid ones, the amyloid positives, and so on. The next figure, the same with p-tau. And you can see that all of these biomarker groups, we found significant or at least a statistical trend level association. So higher CAIDA score were associated in all of these groups with higher risk, higher speed for with dementia progression. Here is the same results regarding on amyloid and tau negativity, and when both proteins were pathological, we find also a significant association regarding high CARDA score and dementia progression. In the case of smoking, we find that in the amyloid positive subgroup, there is a significant association with higher progression rate and also a statistical trend level association in the tau positive group. Let's see, depression. In the case of depression, we find significant association in the tau positive group and the statistical trend level association in the amyloid and tau positive group. I know it was a lot of information, so I made this summary, you can see, again, high KIDA score was associated with every biomarker subgroups with higher progression rate, smoking in amyloid positive and tau positive, and depression and tau positive, and when we know that both proteins are in the pathological level. I mentioned our limitations, some of the limitations. It's very important to keep in mind that we use these risk factors as categorical variables, so without accounting for severity of condition or use of medications. And regarding the cognitively unimpaired groups, we found no significant association in any of the biomarker subgroups. We assume that this because of the low statistical power, for example, by the relatively low progression rate in that group and the short follow-up period for a cognitively unimpaired individual. So we arrived to our conclusion. Simple, but we hope it's very relevant, that even after the onset of Alzheimer pathology, addressing these modifiable risk factors remain critical to reducing the risk of dementia. We believe, we point out that the possibility or the potential of integrating biomarker-based risk stratification with assessment of modifiable risk factors. Early interventions should target these modifiable risk factors, but not only early intervention, because just imagine a patient where we use who get anti-amyloid therapy, which is a super expensive therapy. Even that case is still very important to also address these simple but important factors. For future research, our implication is that interaction between these biomarkers and modifiable risk factors should be understood even more detailedly. I already mentioned the limitations with the CU population. It's needed further studies with larger samples and longer follow-up period. And there are already existing interventional trials which investigate the effect of the lifestyle changing intervention. And these randomized control trials should evaluate the impact of the risk factor management, stratifying or at least adjusting by different biomarker profiles. So it was the scientific part of my lecture. In the end, let me share a quote. Az emberért megyünk mi küzdelembe, a fegyverünk tudás és szeretet. And I'm very happy to express my gratitude to my dear supervisor, Gábor Csukli, also to Péter Hegyi, Mari Anna N, and the whole CTM team, to János Réthei and all my dear colleagues at the psychiatric clinics, and my family and girlfriend. Thank you very much for your attention. I'm very happy if you have questions and I can answer.
Thank you. Congratulations, it was a really impressive work. So I have actually, so as far as SRC, you are progressing towards some kind of screening with this technique. So which methodology can be used for screening of patients? The PET-CT technology or the liquor testing, and what is the cost and safety of these methods?
Thank you very much. This is interesting and obviously very important terms of this this problem. As you remember, we made our analysis based on either cerebrospinal fluid examination or PET examination. The PET is much more comfortable for a patient, but is very expensive. It's a few years ago, at least, it was 6,000 Hungarian forint. Maybe it's changed. And obviously, to ask a patient for a cerebrospinal fluid examination is much more cheaper, but an invasive, painful, or at least very annoying intervention. So the good news that the NIA Alzheimer Association in 2024 wrote a new recommendation, and in that one, they also recommend for use the serum examination. There is the PETA 217, which is in the first level recommended to examine regarding this question, and it turns the second question that it's a p-tau, but they find that p-tau variant, because p-tau is a protein family actually, there are different proteins in that group, it's really closely associated with the pathological amyloid status.
Thank you very much, and if you don't mind, I have another question. In your study, in the first one and the second one, you analyzed data on patients without cognitive impairment. So why those patients were tested in the first place? And is there any selection bias there?
Thank you very much. We address these questions. So first I answer the first part of the question. There are memory clinics, and typically there are two reasons when individuals go to these memory clinics. They worry about their cognitive status, or they experience some change in their cognitive behavior, cognitive functions. And this is important because there is a so-called subjective cognitive decline, which is not measurable, not detectable by cognitive tests, but there is a long literature behind this that is still a risk factor. And few of, or at least one of the included studies examined on the CU population only this subjective cognitive, only the population with this subjective cognitive decline. Yeah, it's a source of heterogeneity.
Thank you very much.
That how do you see the role of the digital technologies and, example, remote cognitive monitoring, such as the smartphone-based assessment of the variables with variable sensors in the future of dementia risk assessment and prevention also?
Thank you very much. So we know that dementia is a very common disorder, disease. Actually, it's a, okay, I won't introduce this, but dementia is a symptom, and there are different cases of dementia. We all know this. So what I wanted to point out, this is very common, and not the psychiatric technologies that are in the first line. And our second study was about this simple but very relevant modifiable risk factors. And these new technologies, new developments, really helpful to detect early the cognitive impairment and recognize and screen the patients with the higher risk for cognitive decline. So luckily there is, I know, a relatively active development regarding this, and I find it's very, very relevant because one of the key is to find the patients as soon as possible.
In Szeged, we have a new innovation technology, the speech gap program, an application in mobile phone that is a diagnostic investigation and development.
Unfortunately, I don't know it's feasible.
Your previously mentors created this.
With Magdalena Felkácsky.
So maybe this is not strictly your topic, but so what about, because you mentioned that there are people who have this these biomarkers but don't actually have any kind of measurable cognitive decline. So how about, are there any people who have measurable cognitive decline but don't have this pathology? And what about these modifiable risk factors in their case? Do you know anything about that? Or how would you go about measuring it? Because I think some people already raised some points about, people who usually go to these memory clinics are people who have some problems.
So yeah, Azbek, do I understand the question? The first part of the question is how we define, for example, the cognitive impairment, or how we decide between the severity of the cognitive impairment?
No, it's about whether you have any information of people who have the cognitive impairment but don't have the amyloid pathology or the other one.
Oh yes, we have information. So as I unfortunately mentioned, that dementia is a symptom and there are many other causes. The second most common is the vascular dementia. So some people can have MCI, mild cognitive impairment, or dementia without these pathological changes, but caused by vascular encephalopathy or Lewy body dementia, frontotemporal dementia. There is a newly recognized but very important dementia type, the so-called late, the limbic predominant TDP43 encephalopathy. So there are many. Alzheimer's is the most common type of dementia, but there are many other types.
Yes, and so how would you? So what's the kind of status of these modifiable risk factors?
Oh, sorry.
In the cases where you don't have the.
Yeah, now I remember that was also in the. So thank you. This is why we figured out our second study, because we have information that for the dementia syndrome, these are risk factors, modifiable risk factors are for the dementia et al. And we were curious that in the terms of more specific, to phrase this question more specifically regarding separately the biomarker groups related to Alzheimer. So if you accept this question, it's general risk factors for dementia, and that's what we investigated this in terms of Alzheimer pathology.
Okay, but so you didn't have, or did you have like groups that like would be negative on most of them? Because in the analysis, yes, but in the second one.
Yes, we have. Thank you. So I showed a high CAIDA score. There you can see the case, for example, when both amyloid was in the normal level and also tau was in the normal level. We can assume that the patients who progress to dementia have, for example, vascular type dementia. So we address this question. The problem that in the clinical practice, we diagnose dementia by the clinical symptoms, and there is a huge overlap between the diagnosis and the protein status. So it's further research needs to clarify more detailedly.
Yeah, so I guess the third part of my question would have been, how would you find people that are like kind of the negative group of all of them, so who have like no cognitive symptoms and no kind of pathology, but might eventually progress, so that you can kind of follow them in like, you know, some kind of a cohort study or something. So how would you find like a negative group, I guess?
How would I find those who progress or not progress?
So like if you're trying to kind of do like a follow-up study where you see like people with or without the risk factors progressing or not progressing, and then you would need like a group that doesn't have the biomarkers and doesn't have any current kind of cognitive symptoms.
Very simple, very easy. Sorry.
Yes.
It's the subjective memory complaint.
Maybe I don't understand the part of the question. So
this question is on the clinical practice. How will you find patients who are not cognitive impairment and negative status regarding the biomarkers?
Define or fine?
Fine.
Fine, sorry. There is a memory clinic. They volunteer for investigation. They worried about, or they maybe feel some subjective cognitive impairment. That's why they come to our clinic. So it's yeah, sorry, I didn't understand first, but it's very easy to find these individuals because why we go to screen our I don't know, our lung. They volunteer.
But maybe the question is, do you find, are there healthy cohorts randomly collected in in Budapest, just that aged matched, and then looked for all these biomarkers as well as the risk factors that could be your control group. So not obviously coming to clinical assessments, but being assessed as potentially healthy volunteers.
It would be more beneficial because that could cause a sampling bias if we only investigate those individuals who go for a memory clinic. Yes, but considering the practice, that's what we can, how we can conduct easier examinations or investigations.
I have 3 questions, much easier than this. Can you go to your first source? Yes. Here we are. What I ask is very simple, but at the same time, I mean, quite difficult. Because we see quite a bit of heterogeneity on this. So why is this? I mean, that some studies are actually in the baseline, I would say that some are very successful, right? But you tell us, I mean, maybe that is something on that different stuff. So, and then why then meta-analysis is a kind of good thing about this?
Thank you very much. It's really related to the previous questions. So yes, you can see that the heterogeneity in this group was 73%, which means there are a lot of co-founders who affect the progression to dementia. You can, hope you remember that we conducted a meta-regression analysis, for example, relating to age. For example, yeah, it's not in this group. So age is a serious source of heterogeneity. Also, there are other co-founders, just like the modifiable risk factors, or how we define the healthy population. Do they have subjective cognitive impairment or not? So we see, and this is the answer for your second part of your question, that considering all these source of heterogeneity, all these co-founders, the amyloid positivity is clearly state for a huge odds for further to elevate the odds for progression to dementia.
But at the same time, we see that if the sample number is small, I mean, that could be actually quite shaky, I would say, that the outcomes.
Yes, it's also, yeah, some of the, in the extreme values, you can see it's relatively small samples.
Can we go to your second study background? You see, the US, yeah, the US always ask why didn't you do that? When you do something and you do the certain studies, then it always, I mean, there are always possibilities that you could approach this in a different way. So this is not your study, but this is a kind of basic setting. So now we see this percentage, and then there are many, many components individually, and then they gave a weight for this. So how about interactions? Because that also relates to what you study actually, if you can actually study multiple components together, and then you may get actually much stronger outcomes, I would say.
We were only able to examine the association. We have data actually for all of the examined risk factors, how they interact. We have much more about how they interact with amyloid than with p-tau. We were not able to examine that. I find it very interesting that, for example, it's also, yeah, we can expect this, when we were able to examine the overall cardiovascular risk, our results are most robust comparing when we examine separately depression and smoking. And this also, I think, it's underscored the relevance of the risk estimation tools what we can use.
My last question is are there data, I mean, people who smoke in their whole life, really hard to stop. Still, there are some people who stop smoking at 60, when some of these factors are identified, and then they actually have to face to this, that if I stop smoking, do this and that, then I have a much better outcome. Are there data on that? because clearly we see that there is an association between smoking and dementia. But on the other side, that whether this is a direct relationship or an indirect one. I mean, that could be shown if you get a group, again, this is meta-analysis, I understand, but just for future studies, that if people people stop smoking or get out from a polluted environment and go to another one, I mean, just to show, really just to show the evidence that this is a time.
And thank you very much for asking this, because there are current, very robust, huge randomized control trials just for this lifestyle-changing intervention. I cannot answer regarding specifically only the smoking, but altogether there are studies on changing of the interventions when healthcare provider intervened and help for individuals to change the overall modifiable risk factor profile. And I cannot emphasize enough this relevance, because it's just the difference between to know something, because we are all know and bored how smoking is dangerous and so on, but this is the control arm in that intervention studies. These are randomized control trials. The intervention arm, when the healthcare provider helps to the individuals, they organize regular social programs, provide, if it is needed, cardiology help and other kind of medical examinations, social programs. There are, for example, I guess it was in this year that the US Pointer study, which worked with, I remember, more than 3,000 individuals. There is a European so-called finger study, another one from Australia. So this is one direction to prevent dementia, and it's looks quite cost-effective, even comparing with the very expensive anti-amyloid therapies. Thank you.
Yes, I'm a stroke specialist, therefore I'm asking you, we have seen the huge impact of LDL cholesterol. And do you know anything about the effect of pathomanies on the way how it works? It is simply causing vascular pathology, or are there any ways?
I have a few information regarding the LDL cholesterol. And if this is a question, thank you. I mentioned this is a limitation also, so we investigated total cholesterol, which is not 100% same with the LDL cholesterol, which is the real danger. So LDL cholesterol damage the blood-based barrier, so also to the direction of the vascular encephalopathy or vascular dementia has an effect, and also linked to directly to speed up the amyloid pathology. We know information that when there are more cholesterol, more likely the pathological way of the metabolism of the amyloid precursor protein. But we need to bear in mind that the brain produces their own lipid profile, even cholesterol. So it's not that directly connected, but yes, the higher cholesterol could point directly to speed up the pathological amyloid accumulation and damage the cerebral system.
Thank you. One quick question and a quick answer, please.
Yeah, it's a brief question, but I think the answer can be longer. So what do you think about the relationship between depression and dementia?
Thank you very much for asking this. There's a huge debate that dementia either a risk factor of dementia or early sign of dementia, early symptoms. And probably the answer is that both. And because we are all aware that there are psychological symptoms also of dementia, and one of these is depression. There are many studies that those patients who have also depression progress much more, and also depression linked to directly with amyloid across the HPA axis. And there is one more link that I know that I forget now. So my answer that there are both ways, and I hope that our findings underscore that regardless of the answer of this question, I mean, we have a guess what is the answer. It's very important to take seriously those symptoms and address those symptoms.
Thank you very much. One of the important aspects here of the program is that the first and second year students are also obliged to attend here, so they know what's coming in the years ahead. So that's great. And so maybe I would like to open the floor for further questions of students or other people here in attendance.
Okay, so I'm a second year PhD student and I'm a surgeon, so absolutely far away from your topic and your field. So just jump back to the first forest plot. As you mentioned previously, it is an outlier, the first study. Why?
Thank you for your question.
The direction is
Yes. So talking about this older study, we were thinking a lot about what could be the reason of this. Yeah, it's an outlier, as you said. One of the reasons of this this heterogeneity, this extreme value, could be the small sample, consider only 10 patients had amyloid positivity. It's obviously cause a bias. And also, this study described that this is a study from the US, and the participants were, a huge part of the participants were immigrants from South America, and they speak English as a second language. So maybe that's obviously just an assumption, but maybe the reason that, and we detect dementia, we measure the dementia by cognitive assessment tools, it's only the limitation related to language. We can't be sure, but that's what I know regarding that study. And if you ask this, I also mentioned that the most extreme value, the Hansu, I hope I say his name correctly. So that creates, for example, also you can see the small sample regarding the amyloid positive group, and they worked with amyloid PET, and they excluded from the analysis the so-called borderline patients between the borderline, when they couldn't really decide whether by the imaging is positive from it or not. So probably those patients did not have that severe amyloidosis, and they were excluded. That case, that's certainly a source of heterogeneity.
Hi, my name is Zsolt Huszár. I'm a doctor and a health economist, also did PhD in Semmelweis. And as I'm a health economist, I always look at the bigger picture, and I think that the takeaway from your great work is really that the importance of screening and maybe lifestyle prevention and lifestyle intervention would be very important in our healthcare. And my question would be, what do you think what would be the most important policy interventions in the Hungarian healthcare system that could help find these patients who have predisposition for these kind of dementias?
Thank you very much for asking this. This is the practical part of this study, the translation. I already mentioned those intervention studies, whether intervention only to organize the regular social interactions, regular meeting with healthcare professionals. So it's not the screening, the difficult part, but to really apply these interventions regarding the change of lifestyle, regarding these modifiable risk factors. And I could mention at least 3 RCTs when they measure the effect, all find a significant effect. So the greatest benefit would be when we start apply. And it's not on the psychiatrists and neurologists because it's a much smaller level. But thank you for asking this. This is maybe a take-home message also.
May I also ask a question? You can also take the opposite approach and not take group data, but how is your advice to an individual patient? You're not advising only policies and groups, you often have a one-to-one with the patient. So what is somebody where you think maybe at risk of dementia? Are you advising on a PET scan? What is the consequences? If obesity is such an important risk factor, we have lots of medication that are very powerful, and it's very easy to assess. You put somebody on a scale, give them the medication, and you can assess the effect very easily. So what is your strategy when you are in front of a single patient?
Thank you very much for asking this. Quickly I go, maybe this is the most important from this lecture, this figure. The first answer is very simple. I point the relevance of these modifiable risk factors and advise the patient on the personal level for him or her what is the patient's risk factors. And I'm happy to mention that just a few months ago they were published a study from Israel, and they measured the psychological effect of knowing our amyloid status, because it even there we will start very soon probably using anti-amyloid therapies, but the current protocol is for mild dementia, maybe there will be for mild cognitive impairment. So currently, unfortunately, there is no so direct relevance knowing our amyloid or p-tau status. What that study, we should evaluate carefully, of course, measure the anxiety level and the depression symptoms and the motivation for lifestyle intervention. And they find that no, the anxiety did not elevated by knowing that we have pathological amyloid level, also depression, and both, interestingly, both patients who get know that they have pathological amyloid and both who did not have pathological amyloid level were motivated, more motivated for lifestyle-changing intervention after this this intervention or this screening.
But these were people who came forward because they were interested in the question. It was not a random study.
Yeah, that's why I mentioned that we have to carefully evaluate, interpret this study.
May I have a last one? Thank you.
Thank you.
So just sensitivity and the specificity of these technologies, PET scan and the liquid test. Is it possible that there are patients in your studies who are false positive or false negative?
Thank you. The short answer is yes, very much. To answer a little bit longer, so the amyloid PET were controlled originally with the autopsy results, and the cutoffs were set for cerebrospinal fluid examination regarding amyloid, were set to the PET scan results. And yes, there is some patient who could oscillate between the amyloid positive and negative groups, but still with this limitation, the relevance of the effect is robust. Yes.
Okay, thank you very much. So it's a little suspense now for you. We'll have to go. Thank you for the discussion, and we'll come back after we had our deliberations.
Thank you. Thank you all for this attention.
It's a pleasure to congratulate Dr. Huszár for a wonderful thesis, for a defense well done, with the remarkable grade of 4.83.
Thank you.
So I think a round of applause is in order for everybody.
Thank you.
Supervisors and two promoters that we had a high expectation and you fulfilled them very well done. Thank you.